So as physicians, Jerry and I spend a lot of time working to stay up to date on the latest medical information and advances, but also to sort through the medical controversies, the areas where the experts disagree about testing and treatment, so we can advise our patients. And today, we hope to convince you that when you understand why the experts disagree, you'll be able to make better choices for yourself. How does a patient make the best choice in the face of all this controversy and conflicting advice? We didn't have a ready answer, so we began to search.
So first we went back to the textbooks and we looked at classic medical decision analysis, which comes from economics. And a formula is used to calculate the best decision. And this formula was derived from Daniel Bernoulli, who was a mathematician in Holland in the 1700s. And Bernoulli was looking at decision-making in the marketplace. And he said the best choice is calculated by looking at the probability of a certain outcome and multiplying it by the utility or the impact that that outcome has. Now, in economics, the probability of an outcome might mean selling a certain number of products. And the utility is basically the profit, or more specifically, the impact that the profit has on the bottom line of the company. And this formula underlies much of economic decision analysis. And now it's been imported into medicine. And in medicine, you can estimate the probability of an outcome. For example, a man considering treatment for prostate cancer, he can look at the probability of an outcome of impotence or incontinence after surgery or radiation. But then the question becomes, how do you put a number on the second part of the equation, on the utility, the impact that it has on your life? Now, there are three different methods that have been used in medical decision analysis. And the first is a linear scale from 0 to 1, where 0 is death and 1 is perfect health. And you're supposed to look at the scale and say, if I became impotent or if I had incontinence, my life would be at this point between 0 and 1. The second method is called a time trade-off. And here you're asked, how many years of life would you be willing to give up or trade off in order to avoid becoming impotent or incontinent? And finally is what's called the standard gamble, and this comes from game theory. And you're asked to imagine that there's a magic pill. And this magic pill can completely prevent a certain outcome, like impotence or incontinence, but in a certain fraction of cases, it kills you right off the bat. And then you're asked, what odds would you take to completely avoid the side effect versus dying on the spot? Now, recent research in cognitive psychology has shown that these three methods are all severely flawed. The problem is you cannot reliably forecast your life in the future. You can't accurately understand the impact that a certain outcome will have on your life if you've never experienced it. Also, medical conditions are not static. They're dynamic. A disease evolves over time. Also, people adapt so that the impact on your life is changing. Despite this, these three methods are well established and broadly used in terms of deciding what is best. They are used in calculating what are called QALYs, quality-adjusted life years. They are the basis of decision-making in the United Kingdom for the National Health Service, where they asked 3,000 healthy British citizens, how much time would you trade off, for example, for men, in terms of impotence or incontinence or any other medical condition. And in the United States, they're used by policy analysts and insurance companies. And recently were proposed in the Annals of Internal Medicine to be the basis for making cost-effectiveness decisions as part of the Affordable Care Act, healthcare reform. Now, what happens when you actually speak to people who have a medical condition? It turns out that self-reported quality of life is very different from what we imagine as the quality of life. So, for example, healthy people in Britain say that being blind is 0.5 on a scale of 0 to 1. Being blind reduces the utility of your life by 50%. Now, I happen to have a first cousin who is blind. She has been blind since birth. She was a premature infant. She was treated in the 1940s with high oxygen, which destroyed her vision. She worked her whole life as a teacher. She speaks 4 languages. She is currently retired, serves on the board of directors of her synagogue, and also volunteers in an assisted living facility, helping sight-impaired elderly people learn how to use a Braille keyboard so they can get on the internet. If you told my first cousin that her life was a 0.5 on a scale of 0 to 1, she would slug you. Similarly, men diagnosed with prostate cancer who are followed by so-called watchful waiting or active surveillance, no intervention, versus men who have prostatectomy with a very high rate of outcome of incontinence or impotence. Both groups of men report the quality of their life at the same level. So when you speak to people who actually have medical conditions, their assessment of their own life is very, very different than what people who are healthy or never experienced the condition believe. So this entire structure of medical decision-making is deeply flawed. And Daniel Kahneman, the Nobel laureate in economics, who's a cognitive scientist, recently gave an address to an international meeting of medical decision analysts. And Kahneman said that this paradigm of measuring utility is like measuring the ether in 19th century physics when the ether did not exist.
So we realized the textbooks were not giving us the answers that we were looking for. And then we thought about Sir William Osler, one of the most famous physicians of all times who practiced in the late 1800s and early 1900s. And one of the most famous comments that he made when you're a physician and trying to make a difficult diagnosis, he said, listen to the patient, because if you know how to listen, he's telling you the answer. So we decided to listen to patients. We interviewed scores of patients in great depth, patients of different ages, from different parts of the country, different socioeconomic backgrounds, and with different kinds of medical problems. And then we asked them how they made their medical decisions. And although we found that, of course, people are individual in how they made their decisions, there were common threads. So we wanted to explain these common threads by involving all of you in a thought experiment. So we'd first like to ask you a few questions. So please raise your hand if you yourself have been a patient over the last year. And when I say patient, I mean not only have you been in the emergency room or admitted to a hospital, but have you been for a checkup or to your doctor for a minor issue? Wow, almost 100% here. Okay, good. So now try to remember the experience of being a patient. Try to put yourself in the mindset of being a patient. And now imagine that you're sitting in your doctor's office and your doctor says to you that your blood pressure is too high. And even though you have lost weight, you've changed your diet, you're exercising, your blood pressure has remained too high on several occasions, and it's time for medication. So raise your hand if you want to be proactive, if you want to aim for perfect blood pressure control, and you'll do whatever it takes to get that. Okay? Now raise your hand if you feel that your blood pressure doesn't have to be absolutely perfect, you just want the minimum amount of medication. Wow. So
okay.
Wait, the first group, the first group we call that the Maximalist Mindset. You want to be ahead of the curve, do everything and more. And the second group, the Minimalists, less is more.
So your doctor prescribes the blood pressure medication, and it turns out the medication comes in two forms. One is extracted from an herb, a natural source. The other is made in a laboratory, synthesized using high technology. Both are chemically identical. Both cost the same. Each one costs the same. Your doctor offers you a choice. Raise your hand if you prefer to have a medication from a natural source. Okay? Now raise your hand if you prefer a medication that's synthesized in a laboratory using high tech. Okay. The first group has what we call a naturalism orientation. And this actually represents about 60% of the people in the country, in the United States, based on surveys. And these are, people who prefer to address a medical problem, if possible, looking at natural solutions, herbals, acupuncture for pain, massage, and so on. The second group has what we call a technology orientation. These are people who look for latest high-tech kind of solutions, cutting-edge treatments.
So your doctor gives you a prescription for the medication that you chose, and you fill the prescription, and now you're sitting down and you're about to take your first pill. So raise your hand if you swallow it down, confident that you're on the right path to solving your problem of high blood pressure. Okay, now raise your hand if you take the pill out of the bottle, stare at it for a while, take the package insert out, read the side effects again, and wonder if you really should take it. Ooh. So the first group we call the believers. Believers are certain that there's a good solution for their problem, whatever category of solution it might be, and once they find it, they're ready to go for it. Doubters worry that the treatment might be worse than the disease. So the terms for these mindsets are what came out of the interviews that we did with patients. These were the common threads that we found that reflected their approach to their health in general and to medical problems when they arose. And these approaches were applied not only to problems like high blood pressure or high cholesterol, but also to decisions around surgery and even treatment of cancer.
Now, one of the first patients we spoke with is a woman we call Susan Powell. Everyone we talk about this evening is real, but we changed names for confidentiality. Now, Susan is in her 40s. She works as a nurse's assistant, and on a routine checkup with her primary care physician, was found to have an elevated cholesterol level of 240. This was confirmed on a repeat test, and the normal cutoff now is 200. Now, Susan is a very active person. She walks regularly, follows a healthy diet, doesn't smoke, doesn't have hypertension or diabetes. And her doctor said, Susan, you need treatment for your elevated cholesterol. You need a statin medication. This medication will decrease your risk of a heart attack by 30%. Now, that made an impression on Susan. She said she'd think about it, but didn't immediately fill the prescription. And over the course of the ensuing months, she sought more information about elevated cholesterol and its treatment. And while surfing the internet, she came upon a government website from the NIH that has what's called a risk calculator. And here what you do is you put in your individual characteristics. In her case, her cholesterol level, her age, her gender, the fact she's not a smoker, doesn't have hypertension, and so on. And the risk calculator answers a key question that every patient should ask himself or herself regardless of the medical condition. And that is, what is my risk of a certain outcome without any treatment? Now, for a woman like Susan, in her 40s, with a cholesterol level of 240 and no other risk factors for heart disease, her chance of having a heart attack over the ensuing 10 years is 1 in 100, 1%. Even if she were in her 50s and her cholesterol level had gone as high as 280, her chance for a heart attack in the next 10 years would be 2%, 2 in 100. So you see how your mind plays a trick on you. When you hear that a statin medication will reduce your risk of a heart attack by 30%, it sounds to you as though you are at 100% risk for the heart attack. But in Susan's case, it's really 30% of 1%, or if she were in her 50s with a cholesterol as high as 280, it would be 30% of 2%. And this has a much different impact, clearly, in terms of thinking than what she had originally heard. Now, we spoke with some patients, like a woman we call Michelle Bird. Michelle is a maximalist and a believer. And Michelle said to us, I would definitely take that statin medication. I could be that 1 in 100 who would have the heart attack. But Susan was a minimalist and a doubter and was not convinced by the numbers.
But there's more to Susan's story than just numbers. Shortly after she was given the statin prescription, she went to a dinner at her church. And there she encountered an acquaintance who looked very ill, was hobbling around very uncomfortable. And it turned out, when she went to speak to her, that this woman had been given the very same statin prescription that Susan had been prescribed. And this woman had had a side effect, in fact, the most common side effect of this medication, which is muscle inflammation, myopathy, muscle pain. So as you know, stories like this have powerful effects on all of us. Cognitive scientists call the effect of stories availability, because the powerful story stays in your mind and is readily available. So these kinds of stories lead us to overestimate the likelihood or probability of the same thing happening to us. So although stories can sometimes be helpful, they can also be misleading, making something rare appear likely. So when you hear a story like this, you have to go back to the numbers. You have to know the numbers. How common is this side effect of myopathy when you take a statin? So it turns out that the number ranges from about 1% up to as high as 10%, depending on the type of statin, the dose, other medications that the patient might be taking, and other medical conditions. So 10%, that might sound like a pretty high number. But now let's frame the numbers the opposite way. Between 90 and 99% of patients do not have this side effect of muscle inflammation when taking a statin. And this sounds much better, although the information is just the same. So when presenting information to a patient or considering information for yourself when you're making a decision, it's important to flip the frame and view the information in both the positive and the negative. Now, you might think that framing is primarily a problem for patients, but a recent Swiss study showed that doctors are just as susceptible to the effects of framing as patients are. So how do patients get numbers and other information about medical treatments? Well, one way is through drug advertisements. And a study from UCLA showed that if you watch the evening news and about 2 hours of primetime television, you will see in excess of 1,000 drug advertisements over a year. And this works out to about 16 hours, which is a lot more time than most people spend with their doctor. And these ads are effective. For every $1,000 that's spent on the advertising, 24 new prescriptions are written. So drug ads are carefully constructed to use both the power of numbers and the power of stories to sell their product. So let's look at how it's done. Numbers are framed in the most positive way. For example, a statin advertisement would say that your risk of a heart attack is reduced by 30%, but it's not, they won't say that it's 30% of 1% or 2%. So I'd like you to look at this next slide, which has an ad for a new medication called Pradaxa. Dabigatran is the generic name for it. And this is a medication that was recently approved to treat patients with atrial fibrillation, an abnormal heart rhythm. And this ad came from an internet site for patients. So you see the doctor there, and he's giving the patient the information. And this ad uses numbers very effectively. So it first states that if you have atrial fibrillation, you are up to 5 times more likely to have a stroke. Now, 5 times, this sounds very threatening, clearly implies that you need treatment. But what are the real numbers? What is the baseline risk for atrial fibrillation if you're not treated? So many of you in this audience might know that this depends on what's called a CHAD score, whether or not you have heart failure, high blood pressure, diabetes, your age, and whether or not you've had a prior stroke or other neurological event. And that number varies between 0.5% and 6% for ambulatory patients. So now let's frame those numbers in the opposite way. Between 94% and 99.5% of patients will not have a stroke without any treatment. So obviously these are much less impressive sounding numbers than 5 times increased of risk. So now the ad goes on to say that this new treatment is 35% better than the traditional treatment, which is warfarin. So this also sounds very impressive. But again, what are the actual numbers? So the risk of stroke in the RELY trial, which was the clinical trial used to approve this medication, the risk of stroke was 1.7% with warfarin, the traditional treatment, and 1.1% with the new treatment, a difference of 0.6%. And I think you can all imagine that if I reconfigured this advertisement to say that the new treatment was 0.6% better than the old treatment, you'd be a lot less impressed. So it turns out that when patients hear the numbers the way they're stated in drug advertisements, a study from Dartmouth showed that they typically think their medication is 10 times more effective than it is. Now, this is not just a problem for patients and drug advertisements. It's also a problem for doctors and those of you who are reading clinical studies. So this is a study that I'm sure you all have seen reports on. This is primary prevention of cardiovascular disease with the Mediterranean diet. It came out just a couple of weeks ago in the New England Journal, and I have here the abstract with the results. So what's given here is an adjusted hazard ratio of 0.7, which gives you a relative risk reduction of 30%. And that's the number, I think, that you've probably all heard, maybe even written about. It's been everywhere. So now let's look at the actual numbers in the study. So the cardiovascular events in the control group, there are 4.4% of the controls had a cardiovascular event, either a stroke or heart attack. In the group that was treated with the Mediterranean diet plus extra olive oil, the risk of events, the number of events was 3.8%, 0.6% different. The group that was treated with nuts, 3.4%, a difference of 1%. So you can see you need to be very careful when relative numbers rather than absolute numbers are given. So we've talked about numbers. How about stories? Well, if you've watched any television at all over the last year or two, you have seen a Pradaxa ad. And the one that caught our eye was the one where there's a grandfather and the son and the grandson, and they're all going out to fish on a beautiful summer day. And the clear message here being given that the grandfather has made it to this day in good health by taking this medication. So the advertisers know that the story is powerful, and so they keep the story going, and now the rest of the family comes, everybody's hugging and kissing, the sun is sparkling on the water, and now you get the soft voiceover with the side effects. Serious bleeding, death. And they, of course, don't mention that there's currently no known way to reverse the anticoagulation of Pradaxa the way there is with the traditional treatment of warfarin, nor that there may be an increased risk of heart attack with this new medication.
Since we all tell stories, and when we write articles or are on the radio or TV or on the web, we love the anecdote. And so what advice do you have to journalists, and you're a journalist yourself, Jerry, what advice do you have to us in how we use anecdotes and how to think about what anecdotes we use?
Well, I think, first of all, stories are very powerful. And
can everyone hear? Yeah.
Can you hear me? Yep.
Yeah.
Stories are incredibly powerful, and they're very important because they give the reader, you know, a visual, concrete, immediate sense of the human dimension. I think that it's important to, first of all, balance the story. So everyone wants the extreme. Everyone wants, you know, the one person who survives, but it's also important to talk about the people who don't have the miracle cure or the unexpected outcome. And so I think that that's the first. And the other is to show how the story does or does not fit, I think, in terms of the knowledge about the disease or the process. And I think it's important to go beyond what one of the editors once told me was the "to be sure" sentence. You probably are familiar with that. I'm not really a journalist, so I had to be educated. And Pam, we've written together in newspapers and so on. So you tell this story, and then it says, "To be sure, this only happens once in a million times," right? But then you go on with the rest of it. So you need to have more traction there about where this fits into the larger scope. But I think they're really important, and the power that you have is much greater than the power that we have as physicians. There is no doubt that, as Pam was saying, that like after the vitamin D or whatever, people come to us. This is what I read in the newspaper. This is what I saw on the internet. This is what I heard on the radio. This is what I saw on television. You know, health journalism is the way the vast majority of people both get information and are directed to choices.
Question?
Thank you. I'm Michelle Merrill, a freelance writer in Atlanta. And first, I want to thank you for an excellent presentation. But I wanted to ask you, how do you suggest that patients should cope with the insidious and influence of financial incentives? And in some cases, I'm being somewhat generous, physicians may not actually be conscious of the impact of those financial incentives. So, for example, the urologists are in favor of screening, but of course screening brings them patients. And just to be personal, my daughter recently needed some skin cream and had gone to the dermatologist. When they called me and said, "This cream is no longer available, we have this other cream, it's very expensive, so we can give you this discount card," yada yada. And I said, "Well, I'm thinking the other one's not available anymore. Is there a generic?" "Oh, well, yes." So, it left me thinking, did they not, did a good-looking pharmaceutical representative come to their office and give everybody lunch, and that's why they're prescribing that particular cream? So, I don't, how is a patient, normally you don't even know what the financial implications might be.
Well, thank you, Michelle, for that question. It's an interesting question. So as far as the issue of the urologists and the PSA, that actually has been looked at in a study about VA urologists that practice within the veterans system, where they don't get any more money if they do more operations or less operations. They're salaried. And they screen exactly the same way as any other urologist. So although, of course, there are financial issues surrounding what we recommend and don't recommend that you need to be aware of, but that particular one, I think, is really more their mindset. They believe it's right. Just like Jerry is a maximalist, and he believed it would be right to have the thyroid surgery, and I believe it wouldn't be better not to. This is not financial. This is our mindset. But the issue of financial incentives is, it's a slippery slope. And I think, there's been a lot done in Massachusetts to protect against that. We are, for example, at our hospital, not allowed to give any samples out. We're not allowed to accept drug company dinner money and so on. I think it's an important issue.
I'd also say just the flip side of that, which people are only beginning to realize now, is that as much as I like the governor, and I do like him a lot of these quality contracts are such that the physician now, say someone like Susan Powell, who doesn't want to take a statin, if you can't get your patient's cholesterol below 200, you are publicly rated as providing low quality care. Now, Susan Powell may not want to take a statin, and she could live the rest of her life healthy and happy without a statin. You could negotiate and discuss and so on. But there's another financial pressure which doesn't come from drug companies. It comes from insurance companies and the government to hit quality metrics and coerce patients to do things which they may not really want to do. And then it turns out, if you look, and we've written about this together in the New England Journal and also in the lay press, once you go beyond safety, almost all the quality targets that were set by Medicare in the last 10 years have been overturned. You're probably familiar with diabetes, with having tight control of blood sugar. If you didn't tightly control your blood sugar, you got dinged in terms of pay for performance and a report card. So patients were being coerced to get their blood sugar low, and it turned out that you caused more deaths among an elderly patient population with cardiovascular disease. So there's, from both sides, there's the drug companies and all the personal enrichment, which we are deeply opposed. But then there's a new force, which is to say there's one way to do it. Susan Powell's cholesterol cannot be 201. It has to be 200 or less. And if it's not done, you're going to get paid less from Medicare or Blue Cross.
And not only that, the patient has a higher copay because you're not as good a doctor.
Next question.
I'm interested, since I read the Daniel Kahneman book, Thinking Fast and Slow, and I noticed you made reference to him. What value do you think there'd be in having medical education include some discussion of decision-making, of literally
questions that have health implications? An example in our community right now, the debate over fluoridating the water flared up out of nowhere. And there was a very impassioned segment of the population that was adamantly opposed.
Well, I think the public health dimension, often, for example, using the language may be useful. I mean, it's hard. I mean, you can have, the vaccines and autism as an example, and despite, the Lancet retracting the paper and the British Medical Journal saying that the data were cooked and all of that, you still have people on daytime talk shows saying that, even though there's no difference in autism incidence in thimerosal versus non-thimerosal, I mean, you can go through all the data and can't convince. But I think that understanding the genesis of it, which has to some degree to do with what's called loss aversion. We write about this in the book. We didn't talk about it today, is that people don't want to change the status quo. And in a way, and here stories are very powerful from you, to have a kid in a class get measles and then end up retarded for the rest of his life because of encephalitis, or to have diphtheria come back, or any of these kinds of diseases which have been kept at bay because of effective vaccination. The way to answer from a public health point of view, I think, is not from a numbers or an abstract, but is to show people the risks that they're taking by not doing things that are really prudent and scientifically based.
Next one.
psychology class a long time ago that personality variables are valid to the degree that they predict behavior. And one of the things that I think is very interesting is this mindset that sounds very much like personality variables. And the other thing that I'm very interested in is the e-patient movement, the notion that patients should bring in their own agenda and pursue information and be, and kind of avoid parentalism in medicine sounds very much like the degree to which they insist on their own mindset as opposed to whatever mindset the physician has. So I'm very interested in those two questions in combination. How does mindsets interact between a patient and a physician, and to what degree does that interaction or kind of default settings here?
How many people, for example, with hypertension, who are 70 years old, who have a blood pressure of 165 over 95, clearly elevated, how many people need to be treated to prevent one stroke? Okay? And it varies from study to study, anywhere from 1 in 40 to 1 in 80, which means that 39 to 79 people take the medication with no benefit. For statin medication, for someone like Susan Powell, it's 1 in 300. 299 people take the pill with no benefit. And so some people say, I'm taking it, right? Because I believe that I could be that one. But that gives you a very concrete, clear sense of how much real benefit. And in terms of the question the gentleman asked about public health, most of the policy is not made around individuals. They look at populations. So, 1 in 300 is trivial for a person, but they'll say we're talking about 40 million people. And then it moves into the 10,000s, 100,000s heart attack. So there's a tension there.
The other thing just to keep in mind is that the recommendations and guidelines that come out are changing all the time. So there was a study that looked at how often these guidelines get overturned. So something like 14% at 1 year, I think 20% by 2 years, and I think 33% by 5 years. So, and this is not just because there's new data, but also because the composition of the committee that's making the guidelines changes. So now we've got a few more maximalists or minimalists on your committee, all of a sudden the guidelines change.
So unfortunately we have time just for one more question, and I'm sure that Jerry and Pam will stay to answer your remaining questions. So.
Hi, I'm Grace Rubenstein. I'm an independent journalist in the San Francisco Bay Area, and last year I wrote for theatlantic.com about my own decision whether or not to get the HPV vaccine, despite being older than the recommended age of 26. So here I was considering doing something that was explicitly not recommended for me, but of course those recommendations are based on probabilities for large populations. So here we have a decision that has been made, a specific guideline that says do this or do not do this, and that's a decision that's made for a large population. What does that mean for my decision as an individual? Could you kind of speak to that? How do we make those calculations differently, and how do we cope with that tension?
Well, I think you raise a very important point, and that is that these guidelines are made for populations, and they are based on a selection of data that the particular group picks, and then how they value that data. And you may not be included in the particular population that was looked at, and so then you have to think about the risks and benefits for yourself by thinking of your mindset and looking at the numbers for yourself. And it's an excellent example there that you raise.
I also think what concerns us is that we feel very, very strongly about being against medical paternalism. And in the past, medical paternalism was the doctor who said, you do this, it's my way or the highway, I know best, and so on. But that shifted now. And with all the, quote, good intentions and so on, it's coming out of insurance companies that have these quality contracts or the government. And instead of using guidelines as a guide or a reference point, they have become mandates. And the patient and the physician are being pivoted as adversaries rather than partners.
Yeah, we're very concerned that the role of the doctor, the art, if you will, of medicine and decision making is being taken away by guidelines that become mandates. You're really not supposed to think because here's the rule, just do it. And that's a really serious problem for both doctors and patients.
Thank you very much, Pam and Jerry.